Thank you for allowing me to present our research. We have no disclosures. Rhabdomyosarcoma is a tumor that originates from skeletal muscle. It most commonly affects children and young adults, and it's defined into several histologic subtypes, including embryonal, or ERMS, and alveolar, or ARMS. It is currently treated using multimodal therapy, including chemotherapy, radiation, and surgery. However, the 5-year survival remains at 30% in the most aggressive form of the disease. There are several chemotherapy regimens that include the standard of care, which is vincristine, actinomycin D, and cyclophosphamide. And in the case of relapsed or recurrent disease, alternate chemotherapies are used, including doxorubicin. With all of these systemic chemotherapies, there are toxicities that remain even after completion of the treatment. In order to mitigate some of the systemic toxicity and optimize drug delivery, alternative forms of chemotherapy have been developed. These include liposomal formulations, such as which can be non-thermosensitive, as in the case of Doxil, or thermosensitive liposomal doxorubicin, or TLD. The theory behind these is that normal body temperature of 37 degrees, the drug remains encapsulated within the liposome. However, when heated with mild hyperthermia to around 41 degrees Celsius, the liposome bursts, releasing the drug within the target tumor tissue. This also would limit release within all systemic tissues. These are currently undergoing clinical trials in other solid tumors of breast cancer and hepatocellular carcinoma. In order to heat these in vivo, multiple methods have been tested, including radiofrequency ablation and focused ultrasound. Our experimental protocol for our hyperthermia treatment required a multidisciplinary team from multiple research institutes. Initially, the tumor cells are grown in culture and then injected into the right hind limb of the mouse. They then undergo MRI screen in a 7 Tesla MRI 2 to 3 weeks after injection. And then they are treated using hyperthermia with an IGT small animal HIFU system and controlled by Proteus, which is an open source platform that allows for closed loop control between the MRI and the ultrasound. Our initial pilot studies showed that this was a feasible method of localizing HIFU within the tumor. In this axial MRI image, you can see the tumor circled in red with the region of interest circled in yellow and the corresponding temperatures on the right-hand side. Our 3 criteria for correct treatment included maintaining the region of interest at the target temperature for the duration of treatment, as well as maintaining the animal's core normothermia and having no off-target heating. What we saw is that our heating profile remains stable throughout treatment. We initially have a 1.5 minute preheat cycle that gets the target temperature into the desired range. They then undergo a 10 or 20 minute treatment where the average temperature remained at 41 degrees Celsius plus or minus 1.6 degrees. In our animals, we saw no gross skin burns or tissue damage on necropsy. Over the course of our feasibility study, we saw that there is a very consistent level of the target tumor temperature throughout and between treatments. We then went on to optimize the duration of hyperthermia with drug release. We followed a similar experimental protocol with an MRI screen 2 to 3 weeks after injection, where the mice were then divided into hyperthermia or non-hyperthermia treatment groups. They were then treated for 10 or 20 minutes with either thermosensitive liposomal doxorubicin or standard doxorubicin. The non-hyperthermia mice were treated on average of the same amount of time as the hyperthermia treatment group to account for the extra time spent in the MRI. What we found is that at 20 minutes of hyperthermia, there is a significantly increased amount of drug within the tumor with the TLD compared to the 20-minute control. There was no difference between 10 or 20 minutes in the thermosensitive liposomal doxorubicin groups or between the heated or unheated standard doxorubicin. Additionally, there was significantly more thermosensitive liposomal doxorubicin remaining in the plasma when it was unheated compared to all of the treatment groups of the standard doxorubicin. This shows that TLD is not released when it is unheated. We have several ongoing studies in this project. The first is comparing standard care chemotherapy to our novel treatment. We are analyzing tumor growth and survival. The second is looking at drug accumulation within the other organs as a surrogate for systemic toxicity. The specific organs we are looking at include the heart for cardiotoxicity, the liver and spleen, as these are sites of liposomal accumulation, and the kidneys, as these are the primary clearance site for doxorubicin. In summary, MRgHIFU is a technically feasible method to provide localized heating within a murine RMS model. In using MRgHIFU with thermosensitive liposomal doxorubicin, clinically relevant levels of doxorubicin are reached within the tumors of the mice treated with this novel therapy. And this will form the basis for translation of MRgHIFU and thermosensitive liposomal doxorubicin into further clinical studies. Thank you.